Welcome to the deep dive. Today we're tackling meningoencephalomyelitis of unknown origin. Bit of a mouthful, right? We call it MUO.
Definitely easier to say MUO.
Yeah. So if you're a dog owner, maybe worried about neurological stuff or just interested in vet medicine, this is for you. We've gone through the medical info on MUO, and our mission today is basically to pull out the key information, make this complex thing a bit clearer.
Exactly. MUO, it sounds pretty intimidating, I know, but it's something vets, come across when a dog has neurological signs. So think of this as like a way to get a handle on what it means, why it's still a bit mysterious, and how vets approach it.
Okay, great. Let's jump right in then. MUO. What exactly is it, in simple terms?
Well, simply put, MUO is the term we use when a dog's central nervous system, that's the brain and spinal cord, gets inflamed, and we haven't figured out the exact cause yet.
Okay, so inflammation.
Right. And this inflammation, it can be in just one specific area. We call that focal. Or it might be widespread, kind of diffuse, or it could be in multiple spots, which is multifocal.
So it's less a single disease and more a description of what's happening, like a sign.
That's a really good way to think about it, yeah. And here's something important. You might have heard of GME, Granulomatous Meningoencephalitis.
Vaguely, yes.
Okay, so historically, lots of these inflammatory brain issues in dogs just got lumped under GME. But now we realize using MUO, or sometimes MUE, for etiology instead of origin is actually more accurate when we suspect inflammation but don't know the cause.
Ah, okay. Why the change?
Well, it helps avoid maybe mislabeling something less severe, so MUO is really the go-to term when that unknown part is still true. It keeps things more open.
Got it. Makes sense. The unknown origin part is key. But are there any clues, any working theories about what triggers this inflammation?
Yeah, this is where it gets tricky, and honestly, still a bit of a puzzle. We don't have the definitive cause, but the strongest suspicion points towards viruses maybe playing a role. And also the dog's own immune system getting involved. The current thinking, sort of, is that maybe a virus starts it, and then the immune system kind of overreacts and accidentally attacks the central nervous system.
Wow. So friendly fire from the body's own defenses on the brain or spinal cord?
That's a great analogy, yeah. And we see MUO show up in a few main ways clinically. There's an ocular form, mostly hitting the eyes.
Okay.
A multifocal form, affecting multiple spots in the brain or brain and spinal cord. And then the focal form, where it's really concentrated in just one location.
Now, who gets this? Can any dog develop MUO, or is it more common in certain types?
Good question. Technically, any breed can get MUO, but we do tend to see it perhaps a bit more often in smaller toy breeds.
Interesting.
And there's some thought that maybe these smaller dogs, well, sometimes they might not respond quite as well to treatment. But, and this is really important, it definitely happens in medium and large breeds too. It's not exclusive to small dogs at all.
Right. And what about age? Is it an older dog thing or?
The average age we diagnose it is around 5 years old. But the range is pretty wide, actually. We've seen it in puppies as young as 6 months and in dogs up to 10 years or even older.
Okay. And any difference between males and females?
There seems to be a slight tendency for female dogs to be diagnosed a bit more often. Just slightly.
Is MUO common, or is it considered rare?
That's actually pretty tough to say, for sure. You see, the only way to get a 100% definitive diagnosis is a brain biopsy.
Right, you mentioned that.
Yes.
Sounds invasive.
It is. It's complex, has risks, costs. So it's rarely done while the dog is alive. Because of that, we don't have solid numbers on, incidence or prevalence. Most diagnoses are presumptive, a strong, educated guess based on everything else.
So we don't know exactly how many dogs have it.
Exactly. But the good news is vets are recognizing it more, and we are treating it, often successfully, and it's seen pretty much worldwide.
Okay, so if a dog does have MUO, what might an owner actually notice? What are the red flags?
The signs. Well, they really vary quite a bit. It all depends on which form it is: ocular, multifocal, focal, and crucially, where in the nervous system the inflammation is located. Think of the nervous system like a really complex electrical grid. Where the fault is determines what stops working.
Makes sense. Can we break down the signs for each form? What would you see with the different types?
Sure. So for the form affecting the main part of the brain, the cerebrum, frequent seizures are a really common sign.
Seizures, okay.
With the ocular form affecting the eyes, it's often quite sudden. The dog might become blind very quickly, and you'd notice their pupils are wide open and don't shrink down when you shine a light in them.
Sudden blindness, wow. And the focal form, since it's just one spot, I guess the signs could be really specific depending on which spot.
Precisely. If that focal spot is in the cerebrum, you might see things like disorientation, maybe sudden changes in behavior, seizures again, or a type of blindness where the eyes themselves are okay, but the brain isn't processing the visual information.
Cortical blindness, right.
Exactly. Or compulsive circling, just walking in circles, or even pressing their head against walls or furniture.
Head pressing, okay. What if the focal spot is lower down, like the brainstem?
Right. The brainstem is critical. If the inflammation is there, you might see the dog being really lethargic, sort of somnolent, or problems with cranial nerves, maybe facial paralysis, like a droopy face, or vestibular signs, like a head tilt or loss of balance. Weakness on one side of the body is also possible.
And the spinal cord.
If the focal lesion is in the spinal cord, well, you might see neck pain if it's high up, weakness in all four legs, tetraparesis if it's in the upper neck or chest area of the cord, or just weakness in the back legs, paraparesis if it's lower down. And often they'll seem really uncoordinated, kind of wobbly, what we call proprioceptive ataxia, like they don't quite know where their paws are.
That is a huge range of signs. So if a vet suspects MUO based on some of these, how do they even start figuring it out? Sounds like a diagnostic puzzle.
It really is a puzzle. As I said, the diagnosis is usually presumptive. It's based on putting together a bunch of clues. The dog's history, what the owner tells us, a very careful neurological examination to try and pinpoint the problem area,
Yeah.
analysis of the cerebrospinal fluid, the CSF, and really importantly, MRI scans.
MRI seems key here. Is that the best way to see the inflammation?
Absolutely. MRI gives us the clearest picture of the soft tissues, the brain, and spinal cord. It's much better than X-rays or even CT scans for spotting the kind of changes we see with MUO, like inflammation.
You mentioned CSF analysis, cerebrospinal fluid. What does that tell the vet?
Right. CSF is the fluid that surrounds and protects the brain and the spinal cord. We can collect a small sample, usually from the neck or lower back, under anesthesia.
Okay.
And by analyzing that fluid, we look for signs of inflammation, typically an increase in the number of immune cells, like white blood cells, and usually higher protein levels than normal.
So it confirms there's inflammation happening.
Yes, it's a very strong indicator that something inflammatory is going on within the CNS. But, and this is a key point, it rarely tells us the specific cause. It confirms the battle, like you said earlier, but not necessarily who started it.
Ah, so the unknown origin part often remains even after the CSF tap.
Often, yes. And that leads us to the next big challenge, ruling out everything else that could cause similar signs. We call this building a differential diagnosis list.
What kinds of other things might look like MUO?
Oh, it's a broad list. We have to think about infectious causes first, things like viruses, canine distemper being a big one, but others too. Fungal infections can get into the CNS names like blastomyces, coccidioids, cryptococcus come up.
Fungal, okay.
Then there are tick-borne diseases like Rocky Mountain spotted fever caused by rickettsia or Ehrlichia. Bacterial infections, though maybe less common directly in the brain, are possible. And protozoal infections like Neospora or Toxoplasma.
Wow, lots of infections. What about non-infectious things?
Yes, definitely. There are other specific inflammatory brain diseases like necrotizing encephalitis, which unfortunately affects certain breeds more, like Yorkies, Maltese, Pugs. There's also a type of meningitis that often responds well to steroids, seen more in breeds like Beagles, Bernese Mountain Dogs, Tollers, Weimaraners, Boxers. And depending on the signs, we might need to rule out things like sudden acquired retinal degeneration if blindness is the main sign, or even brain tumors, meningioma, glioma, others, or sometimes structural problems like instability in the neck vertebrae.
Gosh, that really underscores how complex this is. So besides the neuro exam, CSF, MRI, do regular blood tests help at all?
Usually the routine blood work, like the CBC and chemistry panel, comes back pretty normal in dogs with MUO. Sometimes, though, we might see what's called a stress leukogram.
Stress leukogram.
Yeah, it's just a specific pattern of changes in the white blood cell counts that can indicate the body is under significant stress or inflammation. It's not specific to MUO, but it can be a clue. We also use blood tests, serology, to help rule out some of those infectious diseases we talked about by looking for antibodies.
Okay, and back to the MRI. What specific things might a vet see on the scan that shout MUO?
Well, MRI is incredibly helpful. We often see abnormal areas. They could be solitary, just one, or multiple, or sometimes quite spread out. A common finding, especially in the multifocal form, is seeing areas that enhance or light up after we give a contrast agent intravenously.
What does that enhancement mean?
It typically indicates inflammation and a breakdown in the blood-brain barrier. That's like the brain's security gate.
Yeah.
When it's leaky due to inflammation, the contrast agent gets into the tissue. We might also see signs of swelling, what we call mass effect, pushing on surrounding brain tissue, or fluid buildup hydrocephalus if the inflammation blocks normal fluid flow. The lesions themselves often look dark on one type of MRI sequence, T1 weighted, and bright on another, T2 weighted, which is typical for areas with inflammation and edema or swelling. Sometimes we can even see signs of necrosis or tissue death within the lesions.
Let's revisit the CSF analysis quickly. You said increased cells and protein usually indicate inflammation. Are there typical patterns within that?
Generally, yes. In most non-infectious inflammatory conditions, like we suspect MUO is, and also in viral infections, we tend to see mostly mononuclear cells, lymphocytes, and monocytes. That's called mononuclear pleocytosis.
Mononuclear.
Bacterial infections, which are rarer, might show more neutrophils, polymorphonuclear pleocytosis. Fungal and protozoal infections can sometimes cause a mix of cell types, and occasionally with fungal infections, you might actually see the fungal organisms themselves in the CSF. But these are just guidelines. There's definitely overlap, and sometimes the CSF can even look normal or close to normal even with significant disease, so it's just one piece of the puzzle.
And the brain biopsy. We know it's definitive, but risky and costly. So it's not standard practice.
Exactly. It's the gold standard for diagnosis, letting us see the tissue under a microscope, but it's reserved for very specific situations usually, perhaps if treatment isn't working or a tumor is strongly suspected. And that's why technically GME is a histopathologic diagnosis, something confirmed by looking at tissue, often post-mortem, not really a clinical diagnosis made in a living dog based just on signs and other tests.
So if a biopsy was done or seen after death, what's the characteristic microscopic finding for MUO GME?
The hallmark is seeing dense accumulations of those mononuclear immune cells. Lymphocytes, monocytes, plasma cells clustered around the small blood vessels in the affected brain or spinal cord tissue. That perivascular cuffing, as it's called, is really characteristic. Sometimes you might even see visible changes to the tissue itself, like discoloration or softening.
Okay, this gives a really thorough picture of the condition and the diagnosis. Let's shift to treatment. Once a vet has a strong suspicion, a presumptive diagnosis of MUO, what's the approach?
Right, treatment. Well, the initial approach really depends on how sick the dog is. If they're relatively stable, maybe showing mild signs, they can often be managed as an outpatient, starting on medication at home. But if the dog is severely affected, maybe having uncontrolled seizures, very weak, or showing signs of increased pressure in the brain, then hospitalization is usually necessary. We need to monitor them very closely for any decline, check their neurological status frequently, things like pupil responses, their alertness level. There's a risk of brain herniation in severe cases, which is life-threatening.
Wow. And what about supportive care for these hospitalized dogs, or even those at home?
Good nursing care is vital. Intravenous fluids might be needed if they're not eating or drinking, but we have to be cautious not to overhydrate, as that could potentially worsen brain swelling. If they have seizures or are very unsteady, patting the cage or their area is important for safety.
Makes sense.
For dogs that can't move well or are recumbent, turning them regularly helps prevent pressure sores. Activity level needs careful management. Dogs that are ataxic, uncoordinated, need confinement to prevent falls or injuries, and ensuring they get enough calories, sometimes through assisted feeding if necessary, is always crucial.
And communicating with the owner must be so important throughout this.
Absolutely critical. We need to explain clearly that the signs can overlap between different inflammatory diseases, why the diagnostic tests are needed, and what the treatment involves. It's also really important to manage expectations about the prognosis.
Right, the prognosis. You mentioned earlier it might not be as bleak as some older literature suggested.
Exactly. Some older reports, often focused on severe cases confirmed as GME after death, painted a very poor picture. But, clinically, our experience now suggests that a significant number of dogs, perhaps up to 70%, can respond positively to early and appropriate treatment. However, owners need to understand it's often a long haul. Treatment might need to be prolonged, potentially lifelong, often involving long-term immunosuppression, usually with corticosteroids.
Okay, so let's talk medications. What's the mainstay of treatment?
The cornerstone is suppressing that overactive immune response. The drug of choice is typically a corticosteroid. We usually start with a high dose, often dexamethasone for the initial punch, then transition to prednisone for longer-term management.
Prednisone. Okay. How is the dose decided?
We start high to get the inflammation under control, then very gradually taper the dose down over weeks to months based on how the dog's clinical signs are responding. The goal is always to find the lowest effective dose that controls the symptoms while minimizing the potential side effects of long-term steroid use.
What happens if the signs come back when you lower the dose?
That's a common challenge. If relapse occurs during the taper, we usually have to increase the dose again, sometimes back to the previous level or even higher temporarily, and then try tapering even more slowly. Or that's often when we'd consider adding a second immunosuppressive drug alongside the steroid.
And you mentioned side effects. Steroids can have those, right?
Yes, especially long-term. Increased thirst and urination, increased appetite, weight gain, panting, potential for stomach ulcers. So we often use a gastroprotectant medication like omeprazole or famotidine concurrently to help prevent GI issues.
Okay. What about dogs having seizures?
If seizures are part of the clinical picture, then anti-seizure medication is definitely needed. Common choices include phenobarbital, levetiracetam, or zonisamide, sometimes in combination. And for that compulsive circling sign we talked about, sometimes gabapentin can help manage that specific behavior.
Are there times when using steroids is definitely not okay?
Absolutely. This goes back to the differential diagnosis. If an underlying infectious cause, fungal, bacterial protozoal, hasn't been ruled out or treated, giving steroids can be disastrous, allowing the infection to run rampant. That's why diagnostics are so crucial first.
Right.
Also, combining steroids with NSAIDs, non-steroidal anti-inflammatory drugs, significantly increases the risk of serious gastrointestinal ulceration and bleeding, so that's a big no-no. We need a washout period if a dog was on an NSAI recently. And again, that careful tapering is key stopping. Steroids abruptly can cause issues, and relapses during tapering can sometimes be harder to get back under control.
You mentioned adding other immunosuppressants. What are some of those options?
If steroids alone aren't enough, or the side effects are too severe, or we just can't get the dose low enough, we might add drugs like azathioprine, cytosine arabinoside, which often requires specialized administration, cyclosporine, or leflunomide. The choice depends on the specific case, potential side effects of each drug, cost, and how it's administered.
Any other treatment options?
In very specific cases, usually focal disease confirmed by biopsy that hasn't responded to medication, radiation therapy has been used as an alternative, targeting just the inflamed area, but that's less common.
So once a dog is on treatment, what does the ongoing management involve? How often do they need checkups?
Regular follow-up is essential. Initially, we'll want to see them back for neurological rechecks fairly often, maybe every 2 to 4 weeks, to assess their response to treatment and adjust medication doses.
Okay.
If they're on some of those alternative immunosuppressants like azathioprine or leflunomide, regular blood work, CBC, and biochemistry profiles is needed to monitor for potential side effects, such as bone marrow suppression, low white cells or platelets, or liver issues.
And for long-term steroid use?
For dogs on long-term prednisone, we'll periodically monitor their urine, looking for signs of protein loss or urinary tract infections, which can be more common. And remember, zonisamide, the anti-seizure drug. We need to watch for potential side effects like dry eye, KCS, or rarely other immune-mediated problems with that one too.
It's certainly intensive management. Are there potential complications owners should be aware of even with treatment?
Unfortunately, yes. Despite best efforts, some dogs may not respond well, and their neurological signs can worsen. Status epilepticus that's prolonged or cluster seizures can occur and is an emergency.
Scary.
Some dogs might develop cognitive changes, almost like dementia. Brain herniation remains a risk in severe progressive cases, and sadly, MUO can sometimes be fatal despite treatment.
So wrapping up the prognosis, it sounds quite variable.
It really is. The critical message is that it's not automatically a death sentence, unlike maybe the old perception of GME. Many dogs do respond to treatment.
But the uncertainty remains.
Yes, because we rarely have that definitive biopsy in the dogs that survive. We don't know for certain if they truly had what pathologists would call GME, or perhaps a different, maybe less aggressive inflammatory process that falls under the MUO umbrella. So while serious, there is definitely hope for a good quality of life for many dogs with MUO, especially with prompt diagnosis and dedicated long-term care.
This has been incredibly informative, a really deep dive into a complex topic. So to summarize the key takeaways for our listeners about MUO.
I'd say remember, MUO is this broad category for inflammation in the dog's brain or spinal cord when we don't know the exact cause. Diagnosis is a process. Clinical signs, neuroexam, CSF, and especially MRI are key, but definitive diagnosis via biopsy is rare.
Right.
Treatment focuses on immunosuppression, mainly with steroids, sometimes adding other drugs. And importantly, while serious, many dogs can respond well, particularly with early intervention, although treatment is often long-term.
Perfect summary. And to leave our listeners with something to think about. Considering these diagnostic challenges, the fact that MUO likely covers different conditions,
Right.
what kind of future breakthroughs do you think might help? Maybe better diagnostics or understanding the dog's immune system more? What could lead to more targeted, maybe even curative treatments down the line?
That's the crucial question, isn't it? Advancements in non-invasive diagnostics, maybe better biomarkers in blood or CSF, or more refined imaging techniques could help differentiate subtypes of MUO. And definitely, a deeper understanding of the specific immune pathways involved in different dogs could pave the way for more tailored immunotherapies, moving beyond broad suppression. It really highlights the need for ongoing research in veterinary neurology and immunology.
Absolutely. Lots to still learn. Thanks for breaking that all down.
My pleasure. It's an important topic.